Alright, hello everybody, it's Sammy here, and today we are going to be talking about Moyamoya. So I had chosen this patient diagnosis because I had come across it a few times while I was on my acute care rotation during my residency, and I had really never heard of the diagnosis prior to being here on the acute floor. And then also I had talked to some of the other therapists who were coming across this diagnosis who were also not very familiar with it. So I thought this was a really wonderful opportunity to gather some material so other people are also familiarized in case they encounter this patient diagnosis again. So today what we're going to talk about is what Moyamoya is, how does Moyamoya progress, its epidemiological data, the clinical presentation, surgical interventions that our patients may endure having Moyamoya, its prognosis, and then also some helpful outcome measures and patient considerations. So Moyamoya, it means puff of smoke. It was named by the Japanese who first described it, and it was used to describe a hazy appearance of collateral vessels when the terminal portion of the internal carotid progressively becomes occluded, and then the brain becomes perfused by that external carotid and vertebral-basilar artery system. So if you look at this top picture here, you can see where the internal carotid arteries supply the blood to the cerebral areas of the brain. And then here you can see where that circle's at, and that's where that terminal portion of the internal carotid, that's where that Moyamoya is beginning. So going up from that internal carotid to the MCA. It kind of gives a good depiction, oopsie daisy, of where that's occurring. But if you look at the picture below, there's this overgrowth within the artery that causes because the artery begins to narrow and prevents normal blood flow. So to compensate for the lack of blood flow, these new collateral vessels off of the MCA, well, at least it's the MCA in this picture. So right off that internal carotid to the MCA, and then right off there, they have those lenticulostriate arteries, and then it just continues to proliferate there. But it can also occur in other areas, and in a few slides ahead, I'm going to break down the sequence of grading, and we'll go more into depth about the collateral proliferation. But so as the brain's starved for oxygen, it's going to compensate by developing these new collaterals, which is a very common characteristic of Moyamoya. So Moyamoya can be classified in conditions. So when a patient has a diagnosis of just as Moyamoya, this refers to the distinct appearance that is identified on cerebral angiography. So then from there, you can break it down into either disease or syndrome. So if our patients have Moyamoya disease, this is that bilateral stenosis of the internal carotid arteries and its branches, and there's really no known reason why it happens. It's idiopathic. But if you see Moyamoya syndrome, this is where there's those presence of known risk factors. And below, I have mentioned here the risk factors that our patients could have if they have Moyamoya syndrome, which includes sickle cell disease, neurofibromatosis type 1, which is also called Reckling-Hausen's disease, cranial radiation, cardiac or renal disease, and then also trisomy 21. So in this picture here, I just tried to quickly depict just how important that internal carotid artery is. I mean, it's really responsible for 80% of that perfusion to the brain. So once the disease progresses, that external artery, which if you look in that left picture, I tried to highlight some of what the external carotid artery does. The external carotid artery, its main responsibilities are the scalp, the face, the maxilla, the tongue, and then if you look to the right, that vertebral-basilar artery system where it goes up anterior to the midbrain and then a little bit to that frontal region. So those two areas is what compensates once that internal carotid artery is occluded. And ultimately, the brain, even with this compensation, it's not getting enough for our patients to live a good, important, meaningful quality of life. So it's really important to address some of these concerns early on, and I'll continue to talk about that later on, and I'll stop rambling and we'll talk about the Suzuki grading system. So in 1969, there's a staging system for Moyamoya, and it was first described by Suzuki and Takaku. I'm so sorry if I butchered that. And this grading system, it's still used today. So the progression occurs at different rates for all patients, but there tends to be more rapid progressions for children that are between 5 to 10 years of age and those after at or after 40 years of age. So stage 1, you're going to get that internal carotid narrowing. So patients are usually asymptomatic at this time, and they don't really know what's going on just yet. By stage 2, you're starting to get those Moyamoya collaterals, and it's going to continue to progress. But by stage 4, this is when the external carotid artery as well starts to develop collaterals to compensate for the inadequate amount of blood flow. Then by stage 6, you're going to have total occlusion of that internal carotid artery system, and all the Moyamoya associated collaterals are gone by this time, and really it's the main reason we're getting perfusion at this time is because that external carotid artery and that vertebral basilar system. So I wanted to share with you guys an inside view of Moyamoya and its stages of progression. For those who are more visual learners like myself, I thought this was a really great video. It was created by the Cincinnati Children's Hospital, and it shows the progression of Moyamoya and what happens to our patients over time.
Japanese means puff of smoke because of its appearance on a radiograph. This video will show the progression of how vessels can narrow over time. In this picture of normal vessels, you can see the vessels come in and split, going to the side, middle, and back of the brain. The area where they split is where Moyamoya changes occur. Stage 1. The end of the vessels just before the split begins to severely narrow. Some of the small vessels in the branching arteries begin to get big. Stage 2. There is a swelling of the vessels before and after the narrowing as they try to compensate for decreased blood flow. Stage 3 shows continued progression when there is not enough blood supply to the brain coming from the vessels in the neck. There are numerous tiny vessels that spontaneously grow to the side, the back, and the middle. The vessels are called Moyamoya vessels. Stage 4. The newly swollen vessels begin to diminish in size and die. Stage 5. The Moyamoya vessels become nearly absent, and the vessels coming from the neck are extremely small and allow minimal blood flow to the brain. Stage 6. Complete occlusion of the vessels. At all stages, there is a risk of stroke to the brain.
Alright, so hopefully you guys found that helpful. I thought that was a really awesome video. So now diagnosis of Moyamoya requires either cerebral angiography, MRI, or MRA. So if you look at the picture on the left, and this, I tried to draw more or less like the head and then the eyes and the nose for you, but it looks really bad. So let's just keep this a judgment-free zone. So if you look here, where that internal carotid tracing with that black arrow, as you follow it up, and you look up ahead to where those red arrows are at, you can see that small fuzz of blood vessels, and this is what's known as your puff of smoke. That's your collaterals there that are developing and proliferating. And very little of the brain is being supplied by blood. That piping is not delivering the blood where the blood is needed. And if you look up at those green arrows, you should see perfusion there, and it's absent. So the brain's not getting the perfusion that it needs at this time. So the second image here on the right, this is a FLAIR MRI. It's showing in white these high signal intensities that are found within the cortical sulci, and this is known as an IV sign, which is it's a commonly identified characteristic for those with Moyamoya disease due to its occlusive nature of the disease and the arteries that are involved. Now, the main takeaway from this slide is that Moyamoya more predominantly occurs in Japan and Korea. Sadly, this is actually the leading cause of stroke in children and young adults in this area. There also tends to be a 2-to-1 female to male ratio for those of Asian descent, and for those of Caucasian descent, it's actually a little bit higher at 3-to-1. And then how I had mentioned earlier, the peak age is from 5 to 10 years of age, and then again at 40 years of age, you tend to see a spike in those that are diagnosed. So I want to take the time to mention that although Moyamoya is common for those of whom are of Asian descent, there is still a number of patients of Caucasian descent who are developing Moyamoya and its variants. Now, in 2019, the Journal of Neurology had published the largest retrospective study on those of Caucasian descent with Moyamoya and identified a more in-depth analysis looking at demographic data and its clinical features. So, of the 200 patients, the great majority of patients experience ischemic cerebral symptoms. So 71.5% were diagnosed with at least one TIA, 82% was stroke on retrospective analysis, and then 9.5% suffered from cerebral or subarachnoid hemorrhage. Now, these numbers really follow suit with those of Asian descent, except for hemorrhage. So those who suffer hemorrhagic stroke, or it tends to be higher for those of Asian descent than it does for those of Caucasian descent. Now, 50% experience headaches, and infrequently syncope or cognitive deficits were also identified. But I also want to emphasize one of the associated clinical features was this arterial hypertension, which was experienced by 50% of all of the patients. So in terms of cerebral ischemia, though, the regions of the brain supplied by the enterocarotid, to MCA, these regions include our frontal lobe, parietal lobe, and the temporal lobes. So we've worked with patients with these symptoms with involvement in these regions, such as hemiparesis, dysarthria, aphasia, and cognitive impairments. And these all tend to be common, and these are all things I know everyone listening here is pretty familiar with working here at Honor Health. So in some aspects, it's just like any other one of our patients, where we're identifying the deficits and treating as we see it. Now, so there's a couple of methods that our patients, or a couple surgical methods that our patients may experience once they're diagnosed with Moyamoya, and I wanted to talk about a couple of those common techniques. And the first one is direct revascularization. So after our patients have an operation where there's direct revascularization, they'll immediately start to begin having perfusion. So there's two bypass techniques that are very commonly used. There's the superficial temporal artery to the middle cerebral artery bypass, or there's a middle meningeal artery to the MCA bypass, and these tend to be the most common. Now, the direct method is technically difficult to perform in children because of the small size of the donor or the recipient vessels. Now, in the pictures I have here, so the picture shows the superficial temporal artery to middle cerebral artery bypass. So if you look in picture A, so after opening the skin, you see that superficial temporal artery. It's usually a little bit anterior to the ear, and they first dissect that out, and then by in this picture here next to it in B, this is where the craniotomy is. They perform multiple burr holes, and so these burr holes, if you look at the photo of this very detailed picture with all the circles on his head, those are those burr holes I'm talking about. So they'll do some burr holes, and what they're doing is trying to preserve the middle meningeal artery as well, and the dura is open to find a recipient branch of the MCA. And then after the craniotomy is performed in C, that's when that anastomosis is performed, and the bypass, depending what type they have, it comes together. And then, like I said, they'll have direct perfusion after having this operation. Now for the indirect technique. The indirect technique does not increase cerebral blood flow immediate, but rather the indirect technique is really most often used in cases of cerebral ischemia or those young in age. And the biggest difference between the direct and indirect is it usually takes about 6 to 12 months following the intervention, especially in cases that occur with a cerebral ischemia, to start to get benefits from the operation. So underneath here, I have depicted what is called epilepsy. This is what's most often used with children, where the superficial temporal artery is taken, there's an opening made in the skull, and then the artery is laid down with the aim to get branches to grow into the brain itself. So it's like when you lay a seed in the dirt and then you water it, and then the roots start to grow down. It's very similar to that. But I also took the time to find a video for, again, anyone that's visual and that likes to just have a more in-depth understanding. Now, there was a really awesome video that's only a few seconds long. I just took a small clip. It was made by the Children's Hospital of Philadelphia, and this is that pleocenangiosis that I was talking
artery
about.
That's quite free on top of the brain, and then we put the skull back over top, notching out holes on either side, allowing it to come in, go down on the brain, and come back out into the scalp. Because the brain is trying to get arteries growing into it, that little branches will start growing from that artery, and then you can see huge blood flow through the brain from that.
All right. So that was that method. And then, so lastly, there's one other indirect revascularization technique that I found that was used often in literature, and it was where they create multiple burr holes with the aim of cerebral revascularization, and it tends to occur where those burr hole sites are. So one of the patients I saw when I was here on the acute floor, that was their first intervention. They had started with these burr holes before trying to do anything more aggressive in nature. So, prognosis. Now, the natural history of Moyamoya is variable. Disease progression can be slow with rare, intermittent events or with rapid neurological decline. However, regardless of the course, Moyamoya inevitably progresses in the majority of our patients. Now, disease progression is high, even among asymptomatic patients, and medical therapy alone does not halt the disease progression, unfortunately. But it has been estimated that up to 2/3 of patients with Moyamoya have symptomatic progression over a 5-year period, and the outcome is very poor without treatment. But in contrast, the estimated rate of symptomatic progression is only 2.6% after having surgery, according to this meta-analysis I had read involving 1,156 patients, which is amazing. In general, though, neurological status at the time of treatment, more than the patient's age, predicts long-term outcome. So it's really important to diagnose Moyamoya and have it coupled with therapy to have the most paramount impact on our patients. So patients with Moyamoya have an additional risk of ischemic events during the perioperative phase. And so potential complications after surgery for Moyamoya, they include stroke, infection, and intracranial hemorrhage. So at this time, education is key during the acute stage, so we can reduce the post-operative stroke chances and then shorten our patient's hospitalization stay, like I talked about. And some of the things I never really thought about before are really important for this patient population. So you want your patients really to avoid crying or hyperventilating. This can cause the partial pressure of the carbon dioxide and induce ischemia due to cerebral vasoconstriction. So you also, another thing that I actually didn't know either was the importance of effective pain control around the perioperative stage. They often do like a perioperative sedation. They like to do painless wound dressing techniques. They'll do wound closures with absorbable sutures to prevent that pain of the suture being removed, to reduce the likelihood of a post-operative stroke, therefore shortening the duration of the hospitalization. And then another really important thing is you want to educate your patients on the importance of staying hydrated because dehydration is another way in which our vessels tend to vasoconstrict. So on the Academy of Neurological Physical Therapy website, they have these stroke edge 2 recommendations that were modified in 2018, and really the focus is on stroke specific measures under the stroke category, of course. And this really goes over a literature review that's from 2010 to 2015, and the analysis of the originally recommended outcome measures where they were seeing what's best for these patient diagnoses and populations, just to familiarize you guys if you haven't really looked at this before. And in this slide, I put what's highly recommended for those in the during their acute stay. And I want to take the time to go over those measures with you briefly. So, like I said, in this slide, it demonstrates the 3 highly recommended measures. And then there's more measures you can look at too that you can familiarize yourself with, but because there's so many measures and there's only 3 highly recommended, I really want to take the time to focus on these. So the Orpington Prognostic Scale, the OPS, also known as the OPS, it enables clinicians and researchers to stratify clients into either like a good, an intermediate, or a poor prognosis group by using established cutoff scores, assessing motor, proprioception, balance, and then also cognition. So then we have the Postural Assessment Scale for stroke patient. It says for stroke patients, but I like patients with stroke, but I didn't make the scale. So the scale comprises 12 items with increasing difficulty, which measures balance in lying, sitting, and then again in standing. Then we have the Stroke Rehabilitation Assessment of Movement, also known as the STREAM. And then the STREAM provides a quantitative evaluation of motor function for patients with stroke. And so prior to my rotation, I really wasn't very familiar with the STREAM, so I had looked up some information to kind of help educate me more. And I found a really good clip from Vimeo. At like the first 50 seconds, I would just fast forward it if you do want to watch it, because it just kind of goes over what's on the exam without really teaching you how to administer it if you want like a visual representation of it. And then after those 50 seconds, they have patient examples, and I thought it was really helpful for me. So that is all for Moyamoya. So I really hope you guys have a better understanding what Moyamoya is, how it progresses, from understanding it from an epidemiological standpoint, the clinical presentation, surgical interventions that our patients may have in our care, especially if you're on the acute floor, or even in the rehab setting, or if you're taking care of someone in the perioperative stage. Also their prognosis, and then some helpful outcome measures and patient considerations. So at this time, I just want to take the time to say thank you to all my mentors, Jamie, Tanya, Kim, Candace, Megan. I just want to say thank you from the bottom of my heart for all your guidance, and thank you just for believing in me. And I hope in the future I make you guys proud as a neurotherapist. I truly don't believe I'd be where I am without your tough love and all your guidance that you've given me over this past year. So thank you. And I will leave you guys with this beautiful quote: education is the most powerful weapon you can use to change the world. And I very strongly believe that, especially as a therapist. So that is it. I'm going to stop rambling. I hope you guys have a wonderful morning, day, or night, whatever time it is that you're watching this. And that's it. Thank you guys for tuning in.